In the interest of time, I think we should quickly start. We'll introduce afterwards our panelists, but first of all, we have the channel who's going to start with the first lecture, acute stent thrombosis with sub-intimal wiring. How would I treat?
Thank you, Chairman. Thank you, the organizing committee, to invite me. So I need to be quick because I'm afraid I'm cut in the middle of the slide. So my topic is acute stent thrombosis. Unfortunately, has some complication. How will I treat? Okay, So my case history is a 50 years old man, smokers, hyperlipidemias, coming with STEMIs with an ST elevation over the inferior legs, present with chest of 2 hours, echoes, some regional wall, motion abnormality, otherwise unremarkable. And this is the angiogram. The left side is calcified but not occlusive. But basically, the target is RCA. You can see the outside. How can I go back and pray? Is it? Can I pray? How can I pray?
Oh, yeah, just go back. Yeah.
Okay. Okay, I cannot go back. Okay. Wow, the slide is difficult. Here. So basically, it's occluded outside. It's very calcified. After wiring and doing some ballooning, really aggressive ballooning, and then the operators decide to put in stent, the long stent 3.5 DES. And this is the final angiographic result. You can see the left side, maybe some spasm, but definitely there's some haziness over the distal stent edge together with the in-stent. At that juncture, after some IC nitro, I think the distal stent edge cleared up a little bit. The operator at that juncture didn't really put our imaging to clarify what's happening, and then actually the patient's symptom improved with ECG resolutions. But unfortunately, the patient actually, after an hour, present with increasing chest pain and acceleration again, and this is the angiogram. So you can see the RCA, of course, was occluded. There's suspicious from the first finishing angio, there's haziness inside the mid-stent together with distal stent edge. So, of course, there's a lot of causes for acute stent thrombosis. In this particular case, of course, the high on the list will be these edge dissections. I think you have seen similar case in the room A. Some of my colleagues has already presented a very similar case of outside STEMI together with a stent edge, distal stent edge dissections. This case is very similar. Of course, there's also elements of stent unexpansions because of calcifications. No imaging has been done. Long stents also have been performed in this case. Of course, at the end of the day, of course, pharmacology is particularly important. In this particular case, by default, all our STEMI cases are loaded with aspirin together with ticagrelor 180 milligrams. So we try to wire the RCA, but you can see I intentionally capture the whole fluoroscopy that my colleagues actually have recorded. You can see just want to let you to judge whether it's any problems. No, right? Okay. Some of you shaking your head. Yeah.
But we can make it also interactive,
right?
If that's agree because we have like a 15 minutes for each. We can make it interactive instead of having a. So some points here, some ideas about this wire struggling at the end.
Right. I think at the beginning, it's within the stand, pretty much is okay. But when is exit this distal stand, there's something, right?
So let me introduce Inhan, Ramesh, and Dr. Do as the panelist here. In the meantime, any comments from?
Are you happy with this writing? Or?
Certainly not, but who dares to say? You have. Maybe we can ask AI. What do you think? Something is wrong, but I think maybe
it looks like,
nobody dares to say something, yeah?
No, I mean, first of all, your title already says it. Your entry is fine, but your exit, I think the wire is straightened as well. Yeah.
So this is time to pull out the imaging, and I just let you run to see what you can see. And at that juncture, I think the title I already showed you what happened. At that juncture, I was called in to get help after the operator saw this iris imaging. Of course, the patient still still in the ST elevation, maybe even more worse, right? But the hemodynamic is pretty more stable, right? So I keep it running, and then the next slide I will show the schematic still image of the whole run, right? You can also see the mid stem segments, the haziness, probably because of the underlying calcified essential calcification, no nodule. So the stent expansion is not the best. Okay, so I pray once again. You can see. So distal, you can see very clearly. You can only see the true lumen is very compressed. You are in all the way in the sub-intimal, all the way to the distal vessel, right? You can see the transition shortly come into place here, just at the stent edge, right? So here, exactly. So the case this morning in other room is very lucky because same stent edge dissections, but the wire go in the true lumen and then a happy ending, right? For this, so it's not that easy, right? So schematic diagram you see from the left upper corner, this proximal stent is the essential calcification all the way. Is expansion is okay until the third, the left lower one. You can see there's edge dissections, and then the wire actually go outside into the subminimal plane and wiring all the way. You can see retrospectively when you review the wiring fluoroscopy, you can see there's some difficulty and then some knuckling, and that probably is, I retrospectively we see this knuckling all the way down to the subminimal plane to the acre. So how can you treat? So any thoughts from the panels?
The question is, when at the end of the first procedure, patient was fine. ECG
yes,
was
initially it's okay. You can see
amazing,
the free flow, but some
it's
haziness,
amazing,
right?
Things can
Right.
happen.
The operator think that it may be spasm, give some nitro, and then resolve, and then ECG is resolved, everything is happy, and then bring back to the floor for monitoring.
How difficult you put the IVUS catheter in? Is this difficult or easy?
IVUS catheter is easy.
Easy.
I mean, after the wiring, right?
Yeah.
It's easy.
Easy.
Because you see the channel has been, that already have been communicating between the true and false lumen. It's a wiring, you just make it bigger because of part of knuckling. And I suspect the operators at that juncture before I jump in, they also get some contrast, maybe. Yeah, that's why it makes the communication, the connection even more prominent. Right, so the IVUS should not be a lot of problem.
I think it's the only way now you keep the IVUS in and using IVUS guidance to rewire this in the true lumen is the only way.
Yes, okay. So in recap, there is stent under expansion because of underlying calcification, but this is not the culprit of the stent thrombosis of this case, right? It basically is the distal stent edge dissections, and also, unfortunately, it's because of subminimal wiring beyond distal stent edge all the way down, unlike the other case in the other room this morning. So what should you do? So I think very importantly, when I give help, so I think first of all, do not give further contrast, right? Contrast will not help the case. Just disconnect the syringe because every now when the operator becomes nervous, they intend to puff contrast, but it is lethal, right? Because the hematoma will get progress all the way down to the really distal target. So we always will keep for help, ask for help, and give more extra insight. That as mentioned by panelists, IVUS guided rerun is will be the way to help. But even now, you call the surgeons, there's no way to bypass the vessel, right? But it's my yes.
I'm wondering if you can if let's say you remove the IVUS, you can put in a microcatheter and aspirate to decrease the size of the false lumen.
Yes.
Yeah, and then after that you can still put back the IVUS. Because there's a false lumen. I mean, there's a dissection flap. Obviously, the first wire went into the false lumen through the dissection flap. So after you aspirate and decrease the false lumen size, you can use another wire, non-hydrophilic, and point it away from the IVUS. I mean, on the angiographic view, hopefully you can get, and then try to get to the true lumen and use the same IVUS without injecting anything.
Yes, I think it's feasible, but you can see the false lumen is so big. The trick, I think,
aspirate.
Right. You may need to use the balloon to block the inflow first because you have keep on of the systemic pressure going in the right coronary. So the draw technique sometimes for this scenario may be difficult unless the trick is you use the balloon to block the opening, and then you just trap your microcatheters or whatever device you want to aspirate, and then you take really long time to aspirate. But once you deflate the balloon, sometimes the blood will go in, and then the hematoma will get accumulated.
But the straw is probably easier in the more proximal location, like a near ostial dissection. Just probably here it's very distal, yeah.
So I keep the wire IFS because it's important to review the imaging at the beginning. You can see the problem is just at the stent edge. You can clearly see the true and the false lumen. I think it's difficult to rewind back into distal target from the true to the false to true, but it's very more easy to rewind at the transition from the true to false, right? So use the IFS real time to mark the position where you are, and then use a very floppy wire. You don't need to have you just use a floppy wire. You make sure the IFS, you can see real time, actually the IFS can show the wire actually go inside the true lumen here. So definitely you need some high resolution or high definition IFS system for you to do this simultaneously together with the IFS, together with the system, right? So actually you can see the wire actually go inside the true lumen already. But you still need to tackle lots of sub-intimal hematomas and how to gain back the flow in the true lumen. So unfortunately, when I want to pass the IFS through the second wire, it gets stuck of the proximal stent edge. It's because the proximal stent edge is a little bit malposed, and then the first wire actually gained through some of the part of the stent truss. So, but I need to do it again. So it's reproducible. So next time I a little bit make a J knuckle through the stent, and then unloop the wire, and then try to wire again of the through the distal center using the IFS guide. And this is after the rewiring. I put the IFS through the second wire. You can see I'm the true lumen all the way from the distal, and you can see how big is the vessel. Distal right is a 2.5, PL is 2.5, the distal right is 3.0. You can see all the way. Now it's getting bigger and bigger, even 3.5. Okay, so you can see the transition point just at the stent edge. Okay, happy? So remember, there is also a big PTA. So we use the dual lumen catheters to rewire the PTA as well, using the previous IFS marking the origin. So we use the dual lumen catheters to wire the PTA. This is the PTA IFS spec. You can see the distal healthy. You can see the hematoma there. It is a mixture of contrast and saline, so you can see the stagnant of the fluid. A lot of things. So here now, how can we treat? Even if successfully wire, I want to ask the panel what we do next step. Yes, or the audience, any
who will cut?
suggestion?
Who will cut?
Huh?
I think the first thing you should put the balloon in the true lumen, keep it for maybe a few minutes, and then we can see how the flow is behavior in this case, and then we can do further step.
Quan Lee say you need to cut.
You with the balloon first.
Of course, balloon. But do you afraid of hematoma propagation? It's always the worry.
Because it's already there, so you cannot do anything else with that. So I think that we have to keep it for a few minutes and then IVS again.
Okay.
Who thinks cutting is not a good idea? Because I think few people think we should cut, yeah? Clean it out, yeah? Yeah.
You know, it's not going to be easy to manage the hematoma. You can even use a cutting balloon. You will not cut it most of the time. Now, our experience with hematoma is actually very, very limited. We don't have many, but when you show something like this, you know, it's something that we all appreciate. I'm just toying with the idea whether you can actually use an IVL balloon to actually IVL balloon just to see whether you can actually burst that hematoma. I'm just toying with the idea. I don't know. I'm not very sure.
Oh, that sounds very experimental, yeah.
Yeah, because why not? Why not? Yeah, I'm just experimenting with the idea. But a cutting balloon, I don't know. I've never been successful.
Okay, so I'll show you my successful. Okay.
Yeah, I perhaps would keep the false lumen wire, maybe just stand the distal edge, and then use the straw technique to aspirate the hematoma after sealing the dissection. Because if the dissection flap is open, there's no, we can't straw because the inflow is still keep on going. But if you stand just the distal stent edge, and then you keep on the mid-stent to trap the microcatheter would be fine, and then use it to straw the hematoma. It would be, you don't need to extend the stent to very long, and also it can also help to reduce the hematoma in the false lumen.
I think it is no single answer, but different operators may have different methods. I think what I did, I think Professor Echo has mentioned before. Actually, this is retrospectively. prospectively review. When I'm doing this case, actually, I'm doing quite a number of cutting balloon in this sort of forced lumen reentry or so-called sub-intimal wiring and then going back to true lumen in many of the CTO case. So some of the literature actually mentioned about a cutting balloon. Actually, there's a lot of controversy. How big is it? How big pressure you're going up? Whether you are using the blade, different kinds of cutting or scoring balloon. But I found the roof ring, the cutting balloon is the best. And also, there's some paper talking about pushing the balloon alongside, but I think a little bit risky because I actually perfed one before. So my strategy is try to downsize the cutting balloon a little bit. You have an IFS to see the true adventitious size. So I usually downsize a bit and then pull up to 16. And then while it's deflating, I try to pull a little bit while the balloon is deflating, not really very traumatic. Actually, we try to help to cut or fenestrate. We want to achieve is the fenestration, right? So this is use a 3.0 balloon at roof ring to cut the distal right. The PL and the PDA is the 2.5. So you can see. And I use a little bit or pull a little bit. So this is the IFS I want to show. That is definitely evidence of fenestration of the intima. You can see all the way. You can see the cracking. So the sizing of the roofing, the cutting balloon is essential. I think it's judging by the image, the size from the imaging. So both PDA and the PL has been fenestrated good enough. So because after that, I think we need to do some stenting. But at that juncture, I decided from the imaging, PL probably is the better fenestrated, whereas PDA is a little bit marginal. So I decided to use a DCB to treat the PL, use along, and then treat the stent, the PDA up to the distal right. So and again, this is basically IFS guided. You're never able to give further contrast, mark the position. The green dot is where the IFS landmark, our reference, both the PL together with the PDA. So this is the only final angiogram I take after the, you can see the good flow everywhere, and this is the angiogram, the IFS on the left. You can see this is the PDA. I think the hematoma can propagate. I think the problem is after stenting, always hematoma can propagate to the side branch or distally, and then distally propagation sometimes is really difficult to treat. So at that juncture, actually the patient symptom improve again, EKG, everything resolve, and everything. So the lesson to learn, I think, is important. Intracorneal imaging will help to solve angiographic ambiguity for PCI. I think particularly if the first PCI had been used imaging, it will save the day, right? Never push soft guide wire into acute occluded vessel with resistance. I think it's important. The fluoroscopy is a very good learning material for you to remember. And IFS will help in understanding mechanism of stent failure in second PCI for sure. Stop contrast injection after sub-intimal wiring, and real-time IFS guided rewiring will help you to regain true lumen access, and cutting balloon can help fenestrate intimal, plug, and decompress the hematoma in forced lumen. So thank you very much.
Yeah, so, well, with my experience with cutting balloon, I agree with you, it helps, okay. But there are also times when it doesn't help. You had one that never helps. I think the nature of the hematoma in the IVUS is important. If you have a very concentric, half moon-like looking one, it's not going to be easy to actually cut the hematoma. And you actually have to start distal where there's no hematoma and work your way backwards. But you have to be very careful because a cutting balloon, especially the Wolverine, I agree with you, will not slip. But because it wouldn't slip and you cut the hematoma, right, you can actually perforate the vessel. Yes. This is a very important point. So you may think you're cutting the hematoma, you're actually going to perforate the vessel.
Yes. Yeah. That's why the sizing is, I think it's particularly important. So you have the information from the IFS, then you can judge. I think you can design and try to use best out of it.
I think you are lucky because this case is hemodynamic quite stable, right? So you did it everything so calmly, but maybe some circumstances when the hemodynamic collapse, everything will be rushed. We cannot do that, in the manner like doing the step by step like that. Yeah.
So it's important to assess the hemodynamic. So in case the patient any issue of hemodynamic, we should support the patient first.
Can you just show the reference you got from the Italian group? I want to make a picture of it.
Oh, sure. Can you go back to my slide?
Yeah.
Yeah, I have one question. Alan, what do you think was the haziness in the middle part of the stent?
It's because of the underlying essential calcification. the stent is not fully expanded, but it's not the culprit of the stent thrombosis.
There was also a little bit of contrast at near ostial site. Can we just have the...
That's some contrast at the ostium of the RCA.
Yeah, I saw it too. Yeah. A little bit,
we have to check again.
Can we see this quickly? Are we a little bit behind?
Eric, we have to go ahead.
Yeah. No, I know we have to go again. Yeah. Otherwise, we look at it at the end of the session, maybe. Yeah.
Right.
Okay. We'll do it at the end. Okay. Sorry.